can just go ahead and get started because it's a couple minutes after the hour.
Okay, let's do it.
So let me just start off by welcoming everyone to our first webinar of 2023 for our Neonatal NIRS Consortium. And before I turn it over to our great speaker today, I just wanted to review the NIRS Consortium, and we hope some of you who haven't joined yet would be interested in joining our listserv so you can hear about future webinars about NIRS. So feel free to shoot me an email if you want to join the listserv. And then we also have our consortium website that's hosted at what's listed below. That's Gabriel Altit's site. So feel free to bookmark that because we have all recordings of previous webinars there. And, you know, just that we hope to use this consortium to kind of like those three bullets at the top: guide clinical use of NIRS, promote NIRS research, and provide educational opportunities. And then please keep in mind that we kind of do this on our own time. And, you know, for that reason, the webinars may not be as regimented as could possibly be, but I hope that it's a good resource for all of you. And we're really happy to kind of grow our neonatal NIRS community. And so definitely let us know if you want to be a speaker in the future, or if you have people that you would recommend as speakers. We'd love to hear what the group is interested in. So with that, I'm going to turn it over to my co-moderator, Zach Vassilis from Washington University in St. Louis, and he's going to, I guess, review the webinar etiquette as well as introduce our speaker for today.
All right, thank you, and welcome everybody. I also wanted to mention, Valerie pointed it out on our website. There's also links to our YouTube channel where all of these recordings are. So if you aren't able to stay for the entire talk today, or interested in previous talks, or want to share with colleagues, feel free to point them that direction. Usually the recording, it takes about a week or so for us to get the recording up for the most recent session. So today we're really excited to hear from Dr. Ronald Bronicki, who is a professor of pediatrics at Baylor College of Medicine and works at Texas Children's Hospital, where he's the associate medical director of the pediatric cardiac intensive care unit. He did a lot of his early training and education in Indiana, at Indiana University, for both undergrad, medical school, and pediatric residency. He made his way over to the Midwest, not too far from here, for fellowship in Chicago at Northwestern University. He has a very illustrious career, many book publications and chapters, and has a long-standing interest in the use of monitoring technology, especially NIRS, in the care of critically ill children, especially with congenital heart disease. So we're really excited to hear his talk today. I'm going to be sharing the screen. For questions, we'll probably wait until the end of the talk to go through questions and answers. But as you think of things, or if you have other thoughts, feel free to go ahead and put them in the chat box at the bottom, and then we'll get back to them all at the end of the talk. So with that, Dr. Bronicki, over to you.
Thanks, Valerie and Zach, for that. And I'll just indicate next would be perfect for the
Can you see it full screen right now, or do I need to?
No, it needs to be expanded.
Okay, well, let's see. I probably need to switch which screen it's on. Sorry.
So as you work on that, I'll just kind of get rolling into it. You know, it's interesting. This is the first time I've given a talk on NIRS to an audience that I think is by and large supportive of NIRS oximetry. Otherwise, it wouldn't be part of your consortium. So this is a little bit different for me. I don't. It's less convincing and perhaps more sharing and thinking out loud, particularly at the end. So this is interesting to me. Zach, I lost the slides altogether there.
Yeah.
There we go. Maybe just that suffices if you. Do you see that well?
Yeah, that's
yeah,
perfect.
looks good to me. Okay,
Okay.
great.
All right, good. Okay, so what a few disclosures or sort of disclosures. I am pro monitoring. I think that'll become evident quickly, and I'll explain that in a bit. I believe I provide a fairly balanced. Oh, You're gonna make me do this from rote, huh?
Sorry, my Zoom crashed on my computer. All right, let's try this one more time here. All right, does that look good now?
Yeah.
Okay.
And I believe I provide a balanced presentation on NIRS. I suppose these are less important for today's audience. My view on NIRS oximetry is that it's a useful monitoring tool, but it has limitations, and we're going to discuss those. And I think those are important for its clinical use, and in particular interpreting the signal. But it too has limitations, just like other monitoring modalities. Another disclaimer, or disclosure rather, the principles and application of NIRS oximetry applies to all ages. I can't overemphasize that enough. I am a pediatric cardiac intensivist. I am boarded in pediatric critical care, but all of these principles apply to a patient, whether in the NICU, preterm, term, pediatric ICU, cardiac ICU, adult ICU. The physiology and the application, the interpretation is the same. And I would argue that actually the diseases, while different, are more similar than dissimilar across the spectrum. So yes, I am not a neonatologist, but the principles and application are the same. And then finally, I should mention that I'm a member of the Medtronic Speakers Bureau. Next. So I added this slide because I think it's unique today that I'm speaking to what I believe are pro-NIRS people, and in particular neonatologists. And as I alluded to, I've given this talk a number of times over the last 20, 25 years, actually, and increasingly so to neonatal groups. And one of the things that I appreciate is that there's a considerable amount of interest in the application of this science, this technology, in the management of perinatal asphyxia and assessing cerebral oxygenation, and perhaps establishing cause and effect and so on and so forth. And I understand that and I respect that, and that seems about right. But I would encourage all of us to consider the broader use of this technology in the assessment of cardiovascular function and systemic global oxygen delivery tissue oxygenation. Yes to perinatal asphyxia, but I'm saying yes to more. And for at least the fact that you all have plenty of cardiovascular disease in your unit, just like we do in our cardiac ICU, and it may contribute, it may either precipitate illness or contribute to critical illness. And these are just a few examples. Perinatal asphyxia often includes myocardial injury, dysfunction, and certainly elevated biventricular afterload, sepsis, PPHN, important heart-lung interactions, particularly when you have high airway pressures, and congenital heart disease, whether you have them pre or perhaps just pre-post surgery, and certainly PDA. So I think you'll see that in my discussion, it's about, in part, perinatal asphyxia. It's also in much greater part about its application to just critical illness that we all love, and where cardiovascular physiology is important, and cardiovascular pathophysiology is often manifest. Next. So our objectives today, this is my approach to it. It's 4 buckets. The first one is the why. Do we need adjunctive monitoring? NIRS oximetry to me falls in that bucket. And that is to discuss the so-called limitations of our standard approach, assessing cardiovascular function, cardiac output, tissue oxygenation. The second one is, how does this box work? Review the technology of NIRS oximetry. And again, I realize that you all are pro-NIRS, so some of this may be already obvious to you, but for the sake of clarity, I'm going to review it in earnest. The third bucket, I think, is key to understanding the technology, but also interpreting, more importantly, interpreting the signal. And that is, we're going to review some essential circulatory physiology and principles of venous oximetry, which I know is a bit off the beaten path for the neonatal realm, but I think it's absolutely necessary to interpret the signal. And then typically I discuss the clinical application and the evidence behind that. I'm not going to do that today. I briefly touch upon what we rely on in the pediatric cardiac literature, and then open it up. That would be our Q&A session that Zach and Valerie can mediate. Okay, next. So the first question is, why do we need adjunctive monitoring? and I can't overemphasize this enough, that our approach to assess cardiovascular function, including oxygen delivery, tissue oxygenation, based on so-called standard hemodynamic parameters and the perfusion examination, is quite limited. Next. I think we'd all agree these are the so-called standard parameters, hemodynamic parameters. I know within the neonatal realm, CVP is invariably not present. So leave it to heart rate, blood pressure, perhaps urine output. And I think if we just think about that a moment, really those parameters say nothing about cardiac output, oxygen delivery, and tissue oxygenation. Next. The literature is replete with these kinds of studies. This is just one of them. Vertical axis, cardiac output, horizontal axis, your capillary refill time. Pediatric patients undergoing elective cardiac catheterization. And what concerns me is where the red arrow is, which is many patients with a normal capillary refill time have actually a measured cardiac output that's quite low. And that's the concern, that's the problem. And really, whether it's cardiac output, asphere, I'm not really sure what capillary refill is supposed to represent, but it doesn't represent much of anything. I get it if it's very prolonged, the patient's ice cold, that the patient's not doing well. But even then, it doesn't say whether it's an output issue, resistance issue, or both. Next. Another pediatric study. This is looking at, on the horizontal axis, measured cardiac index using thermodilution, vertical axis estimated. This is based on an amalgamation of different parameters that we just touched upon, throw in chest x-ray, whatever, and we don't know what we're doing. So again, the red arrow, we think they're doing well and they're not. Next. 2 seconds on this. From the adults, same thing. And I think you'd be hard pressed to find a study in the literature that says that it does have a meaningful relationship, any of these parameters. This one's more robust. It's using a PA catheter. Patients you think that have a filling pressure issue, they don't. Those you think they don't do, and everything in between. Next. And then the other thing that's arguably the holy grail of critical care medicine, and one of the advantages of NIRS oximetry and regional tissue monitoring is this. If you take these global systemic indicators of cardiac output, oxygen delivery, central venous saturations, venous oximetry, lactate levels, they may not reflect local or regional perturbations in tissue oxygenation. And these are just a couple examples. The first one is near and dear to all of you, which is HIE and cerebral ischemia, whether it's due to loss of cerebral pressure auto regulation, as Valerie and her group delineated, or some other mechanism. Perfect example. And then the other one is when you have a limited cardiac output and blood flow is redistributed from less vital organs to maintain perfusion of the most vital organs, the brain and the myocardium, and the respiratory pump. You have a tissue oxygenation issue in the periphery that may not be detected by these central global indicators. These are just a couple examples. If you go back to the 1990s, there is a lot of literature on the potential role of GI tonometry, particularly in adult critical care. It's since fallen by the wayside, but it does bring us to the rationale for renal NIRS oximetry, that it will provide us an earlier, more obvious indication that cardiac output and oxygen delivery is falling rather than it's falling off the cliff. And we'll talk more about that in a moment. Next. And you can just scroll through this one, Zach. This is just showing that NIRS oximetry allows us to, and this is from this Somanetics line, the Medtronic line, the INVOS, where you got renal, mesenteric, and cerebral. As most of you probably know, there's a little bit of literature on mesenteric and a whole lot on renal, particularly in pediatric cardiac, and we'll talk more about that later on, actually at the very end. Next. Yeah. Can't keep up with me, Zach. Next couple of slides are perhaps my opinion, perhaps reality, but I think monitoring provides additional benefits. And these are those, and I don't think you can overstate the importance of these, and they manifest every week in our section. They help you assess the severity of illness. Is it time to go on mechanical support now? Or perhaps we have some time to see if vasoactive support can flip the switch, positive pressure ventilation, you name it, surfactant replacement therapy. It helps you understand underlying pathophysiology. Absolutely. Every day in our unit, make a more timely determination of impending tissue hypoxia. This will come up again when we review venous oximetry. It would be much better to act when we have impending indicators of tissue hypoxia rather than, okay, now we have an elevated lactate level, which by biochemical definition is shock. And then last, it helps you objectively assess the interventions, and in doing so, establish a clinical trajectory. Next. All right, a little bit on spectrophotometry, just a little bit, just to make sure we're on the same page, as it is key to understanding limitations of this technology. I think this is a bit interesting. NIRS oximetry shares the same principles as pulse oximetry and vice versa. They're both largely based on the science of spectroscopy and spectrophotometry. That's the prototype NIRS pulse oximeter from the 1970s. You think about where we are today. This is quite fascinating, and I think most of us would consider it the fifth vital sign. Next. I don't know if any of you have seen this before, but this is the prototype for the NIRS oximeter. This is from Jopsis, who was at Duke. Pretty fascinating how that's undergone some refinement as well. And the algorithm, or at least the schematic for the algorithm on the right. Next. So a real brief review of spectroscopy, spectrophotometry. It is based in large part on the Beer-Lambert law depicted there in the figure, which enables us to measure the concentration of a substance, in this case, oxygenated and deoxygenated hemoglobin moieties in a medium, in this case, tissue. It considers light intensity, light detection, depicted in the figure, and then therefore absorbance. And it relies on a fixed path length of light and the fact that chromophores such as hemoglobin have distinct light absorption behaviors. Next. Because there's considerable scatter in tissue, brain, renal parenchyma, etc., we have to apply the modified Beer-Lambert law. And the reason is, importantly, is that scatter alters the path length of light, and it causes some light to be lost, not detected. And the signal processing, the algorithms, and all these proprietary algorithms are different, rely on not an assumption, but several assumptions and correction factors to then generate that oxygen saturation. Next. So this is from the Medtronic Invos line, a probe, in this case, placed over the brain parenchyma. On one end is LED, emitting near-infrared light, interrogates tissue, at least for this system, some 2 to 3 centimeters deep, interrogating 1 cubic centimeter tissue. And then you have 2 light detectors on the other end, separated in distance. And importantly, this separation allows for what they refer to, or what the science refers to as spatial resolution, to help subtract out the external signal from the deep parenchymal signal, the latter, the one we're interested in, the former serving as a confounder. Next. So this technology measures absorption of light by hemoglobin moieties in the entire tissue field, subtracting out the pulse style signal. An obvious difference between NIRS and pulse oximetry. The signal is processed, that means oxygen saturation is generated. Because the majority of blood in that tissue is venous, and that ratio varies from algorithm to algorithm, this value is viewed as a surrogate for venous oxygen saturation of that particular viscera. Next. So this slide brings it all together. All these algorithms are limited by the following assumptions made: scatter-induced variations in light path length and light loss, the degree of spatial resolution, and the variation in allocation to how you partition the blood, venous versus arterial. As a result, this leads to not only inter-subject variation, but intra-subject variation. Next. So these oximeters measure changes in oxygenated and deoxygenated hemoglobin from an arbitrary baseline. We do know from studies that it tracks changes in the corresponding venous oxygen saturation, however. And for those reasons, it's not the absolute value that we can necessarily trust, but it is validated and approved as a trend monitor. Next. That being said, here's where it gets a little bit confusing and where the art of medicine comes into play. And this certainly is evident in our CICU because we often have central venous oximetry at play. If this is one of many studies that have shown a good correlation between, for example, cerebral NIRS and the corresponding jugular venous oxygen saturation. You see that in the unit. The challenge is that it's not always the case. And the variation between the two can be not insignificant. So what my practice is, and I think others, but not uniformly, is yes, at a minimum, it's a trend monitor. But if you have a central venous saturation that's in the right place, and you have to be careful, you don't have cardiac shunting and so on and so forth, and you show that they approximate one another, then you can perhaps take the absolute value. And that happens not uncommonly in our CICU. I think that's perhaps more of an issue in the neonatal realm where venous oximetry is not as widely subscribed to, if at all. So in any case, that's how we apply, that's how I apply. There is at a minimum the trending value, and in some instances, you can take the absolute value, but you got to verify. Next. Okay, so now the sort of complementary component to interpreting the signal, that's the scientific limitations of the technology and also relevant to the interpretation. The other component of that is we do have to review some essential circulatory physiology and certainly the principles of venous oximetry to interpret the signal as it sits, the signal as it responds to interventions and changes in the disease phenotype and so on and so forth. Next. So any discussion of venous oximetry, and in my mind, any discussion of shock is within the context of a VO2 DO2 framework. So if we drop down below, the oxygen saturation functions as a surrogate for the corresponding venous oxygen saturation of that particular vessel. We mentioned that. With that in mind, applying fixed principle and the principles of venous oximetry, you can manipulate that equation, you can simplify that equation, and it comes down to something like this, which is the extraction ratio, oxygen extraction ratio, and you see it there in front of you. It is equal to oxygen consumption over oxygen delivery, the VO2 DO2 framework. And so if you subscribe to this and you apply it at the bedside, it really is a difference between arterial sat, the corresponding venous oxygen saturation or NIRS oximetry saturation divided by the arterial saturation. When I give this talk on the road, I emphasize that you don't need that equation. You don't need a pencil and paper. You just utilize it, you practice with it, and it soon has become almost secondhand. And all of these values are ish anyway. NIRS oximetry has limitations, as does pulse oximetry. So you're looking at ranges and then deducing whether it's increased or decreased or unaffected. Now, you can't overstate the importance of the fact that it is a VO2 and DO2 monitor. Next. Perturbations in VO2 or DO2 may or may not alter the extraction ratio. We'll dive into that in a bit. If you think about it for a moment, the extraction ratio is not an indicator of cardiac function for sure, or cardiac output or oxygen delivery, because oxygen demand varies, can vary quickly between patients, within patients, and as the disease changes and interventions and so on. And you can apply this VO2 DO2 assessment on a global scale or a regional scale. I think we touched on that already. Next. Okay, so now let's apply the VO2 DO2 framework to the bedside. With any perturbation in VO2 DO2, there is a systemic neurohormonal response. So take, for example, any alterations of VO2, and it can go up or down, right? You can go up if you extubate a patient and you load the respiratory muscles, and the converse happens when you intubate, sedate, start, stop, interval feeds, and so on and so forth. So for example, with an increase in demand with exercise, spontaneous respiration as examples, cardiac output and oxygen delivery go up. And when that occurs, the extraction ratio is largely maintained. It's either normal or near normal. If that response is inadequate, then the extraction ratio increases. Along the same lines, with this VO2 DO2 framework in mind, alterations in the determinants of oxygen delivery. As content wanes, waxes and wanes, whether it's due to decrease in oxygenation or oxygen content, oxygen carrying capacity as content decreases, for example, cardiac output increases to compensate for that decrease in content. Delivery should stay the same. The extraction ratio should stay largely the same. If that response is inadequate, and that can certainly happen, and if you go to the extremes of a perturbation in oxygenation or oxygen carrying content, or cardiac output limit, extraction ratio rises. Otherwise, that normal ratio is largely maintained. And as we summarize down below, when oxygen delivery becomes inadequate relative to demand, extraction ratio increases. Next. Then this is what I refer to as the redistribution phenomena. With this neurohormonal response, you obviously get an increase in SVR, but not to all organs. So for example, exercise resistance actually decreases to the largest, if not one of the largest organs in the body, the muscles of locomotion. In any case, it serves to distribute that oxygen delivery accordingly, depending on which tissue beds need it the most. And obviously the brain and the myocardium are sacrificed the least, if at all. And this provides rationale for monitoring regional tissue oxygenation. Next. The other VO2 DO2 component is the regional intrinsic response to a VO2 DO2 perturbation. So every viscera, to varying degrees, has the ability to auto-regulate based on pressure and metabolism. Next. So first, pressure auto-regulation. I think most of us are familiar with this, particularly you all, with your perinatal asphyxia and HIE. This is at the core of it, and this is something that Valerie and her group delineated nicely in the pathophysiology. I think we're all comfortable with the fact that within a given pressure range, flow remains constant. One of the challenges, as I just look at this figure, and I'm talking to a bunch of neonatologists, is the fact that we don't even know, do we necessarily, what is an acceptable blood pressure? Isn't that a matter of debate in your community? Preterm, term? And certainly as a cardiac intensivist, if I have a preterm and a term baby, I think back to what I learned from the neonatologists about their gestational age and that mean blood pressure thing. That's what I use, but you would all agree that we're not quite sure about that. And it gets better with the next slide. But in any case, what we see is the lower inflection point, and you see the corresponding upper inflection point. I think we're all comfortable with that. When we go below the lower inflection point, which is ill-defined, I would actually say it's not defined, but and is as in question, even though we have this sort of reference point with the mean gestational age and blood pressure, mean blood pressure. But in any case, as you fall below it, then you have a passive pressure circulation. As pressure falls, flow falls. That first area, what they refer to here as reserve capacity. Remember, this is a pressure flow relationship. We're just in delivery relative to demand. That's when the extraction ratio begins to rise, when you fall below that lower inflection point from a pressure point of view. Next. This is particularly important, certainly for us in the cardiac ICU, for any critical care doc. This just happens to be that same curve applied to the myocardium, but it's also factoring in oxygen demand. The same is true for your patients when you look at VO2, DO2 brain and you cool or you remove that therapy. You are definitely, obviously, manipulating O2 demand for the brain parenchyma considerably. But in any case, there's a lot of information on the slide. You can look at it into it more on your own, but what it summarizes, go left to right, is that you have to consider demand, not only pressure and flow. If you increase demand, that lower inflection point goes up and to the right. You lose that vasodilatory reserve, because at the end of the day, that's what's happening when you have perturbation in pressure and metabolism. Resistance is changing. The vessel's either dilating or constricting to keep it in line. And it can happen not only as a slight, not only with changes in demand, but also changes in content. Changes in content, changes in demand alter that lower inflection point. And that's an important concept, because before we even got to the slide, we all would agree that we're not even entirely sure where the lower inflection point is in a disease, in a brain that's healthy. Next. And then finally, metabolic autoregulation mediated by a number of things, but for example, ATP metabolic byproducts and so on and so forth. But again, it comes down to coupling DO2 to VO2 such that the extraction ratio is normal, that is largely maintained intact. If you start up at the top left-hand corner, that summarizes why we do an extraction ratio. As your PO2 goes up and down, it stays the same, jugular venous sat in this case, if we apply it to the brain. And that's because the PO2 is greater than 65, the sats are 100%, but as the PO2 falls below 65 and the arterial saturations begin to fall, so too does the jugular venous saturation. But if the cardiac output is not limited, if there's no extremes in content, the extraction ratio should stay the same. If we go to the right, I love this discussion, whether or not we should give blood to a patient and how do you determine whether they benefited from that? Well, if you're not in extremes and you give somebody blood, the extraction ratio won't change. But I promise you the cardiac output will go down, the heart rate will go down, and so on and so forth. In this case, if you apply it to the brain within a reasonable range, the saturation jugular should stay the same, cerebral should stay the same. And then down below, changes in metabolism. If you increase or decrease it, it should stay the same. Next. In any case, or in all cases, when demand exceeds delivery, that's when the extraction ratio rises. And just a word or two on what this increase in extraction represents, because I think sometimes people get hung up on this. The ability of tissues to have an enhanced ability to extract oxygen lies largely with the phenomena of vascular recruitment. This is stimulated, for example, by tissue hypoxia. You increase capillary density, you increase the surface area for gas exchange. When you increase the cross-sectional area of these gas exchange vessels, red blood cell velocity decreases, the transit time increases, allowing more time for diffusion. Just a word or two in that, because I say sometimes it's unclear what exactly it means to have this increased ability to extract. Next. And it's sort of a pre-summary slide. This provides a lot of important information that brings us all together and defines what is normal, what is an elevated critical extraction ratio, what is an elevated extraction rate, and what constitutes critical. And in doing this, we highlight the advantages of NIRS and venous oximetry and show the limitations of, for example, lactate levels. So we'll focus on the figure first. The horizontal axis, we have oxygen delivery, and on the vertical axis, oxygen demand and consumption, although they're not the same. And as we go right to left, and as oxygen delivery decreases, you can see the extraction ratio rises. We talked about that. You can see that VO2 oxygen consumption stays the same, because as that delivery is falling, you have an increase in extraction, which you just covered, to maintain oxygen availability, if you want to call it that. At some point, oxygen delivery continues to decrease, and at that point, oxygen consumption begins to decrease without changing oxygen demand. And that gets a little wonky, but they are two different things. Oxygen delivery and oxygen demand are oxygen consumption, oxygen demand are two different concepts. Without changing demand, as oxygen consumption begins to fall, that is your critical DO2 and your critical extraction ratio. And that critical DO2, as you can imagine, changes in parallel with demand. So if you're exercising, you're running a marathon, critical DO2 rises. And if they fall into Lake Michigan in the winter, critical DO2 falls considerably. But the critical oxygen extraction ratio remains constant because it's looking at one relative to the other. And that critical oxygen extraction ratio appears to be somewhere around 60 to 65%. The other important point to glean from this figure is that the lactate level, and you have lactate level all the time. So if your lactate level, let's just say for the sake of discussion, we all work at the same place, and the lab says the normal value is 2. Anything less than 2 is normal, and whether it goes up or down less than 2, it just doesn't matter, because you produce it and you clear it. You produce it and you clear it. You don't have a lactic acidosis if it's related to a VO2-DO2 disturbance until production exceeds clearance. And you can see from this figure that you can get a perturbation in oxygen delivery. You can have a perturbation in oxygen delivery well before lactate levels begin to accumulate. And what's the signal that gives you that earlier indicator? A rising extraction ratio. And so in my mind, extraction ratios are obviously much more sensitive and an early indicator of a fall in cardiac output and oxygen delivery than a lactate level. And to say that, well, they don't have a lactate level just means that they're not, you don't have evidence that they're in shock, but they can certainly be right at the door. And then obviously, if you have an elevated lactate level and it's due to a VO2, DO2 perturbation, you are by definition in a state of shock. Next. Okay, to summarize a lot of that, we are determining the extraction ratio, and in doing so, evaluating delivery relative to demand. Consider the determinants of VO2, DO2, and the process of the effect of both at the systemic level, the neurohormonal response, and at the regional level, pressure and metabolic autoregulation. You can apply it globally or regionally, and then consider the ranges of oxygen extraction ratio. What's normal, what's impending, and what's critical. Next. And the next couple of slides goes through this. And realize this is for venous oximetry. We already went over the fact that NIRS oximetry is a trend monitor. It has its challenges. Venous oximetry, if you sample a good the blood in the right position without any shunting, it is what it is what it is. So take it with a grain of salt, but these are the normal ranges for the practice of venous oximetry applied to a less precise science. On a global level, a normal mixed for central venous is about 25–30%. If you have a limited cardiac output and oxygen delivery, somewhere in the order of 30–50%-ish. And certainly as it gets to 50–60%, you're in impending shock. And for all the reasons we just discussed, as it rises above 60%, now you're in the critical range. Lactate production should start to exceed clearance, and the lactate levels should start to rise. Next. If you are in a position to assess regional tissue oxygenation, as you can with renal NIRS, here's some values broken down. Cerebral jugular, 35% extraction ratio. If you take all comers and you look at the average cerebral NIRS, it's in the mid-60s. I'm not talking about the preterm term literature that you guys know 1,000 times better than I do. But if you take patients who aren't transitioning from a uterus to an extra uterine environment, mid-60s is what you see. And isn't it coincidental that corresponding jugular venous saturation says 35% extraction? Renal is about 10–15%. Excessive flow relative to demand for its obvious other important function. Gut is about the same as central and cerebral, somewhere around 30%. And then the criticals you see down below. It's unclear what that means for the kidneys. Next. Okay, so that brings us to the last part, and then we'll wrap this up. Evidence and recommendations. It's going to go through a few slides and then open it up for discussions. I suppose this is, well, it may be relevant for today. One of the criticisms I hear, and as I indicated early on, I am pro monitoring, is that there's no evidence that monitoring alters outcomes, and that's true. It's also true, by the way, for all of you neonatologists, that pulse oximetry hasn't been shown to decrease the incidence of anything either, including ROP. And I only know that because I searched the literature high and low, and the evidence doesn't exist. As it turns out for NIRS oximetry, there hasn't been a study done that it's prospective randomized with the purpose of evaluating its impact on outcomes. It's just, they haven't been done. They have been done for all the other monitoring modalities. Nonetheless, you all know that there's numerous prospective observational and retrospective studies on NIRS. The vast majority of it is from the pediatric cardiac critical care literature, but interestingly enough, and perhaps why I'm here today, and I was invited by Zach and Valerie, is that neonatology seems to be getting quite excited about it. And over the last few years, particularly the last 2 or 3 years, increasing number of publications relative specifically to your field. Next. So just 2 or 3 slides, just for the sake of completeness. Next. This is where it comes up in our literature. There's a multitude of publications that have clearly shown a relationship between pre, intraoperative, and postoperative cerebral oxygen saturation levels and extended neurologic injury, and ultimately the association between that signal and neurodevelopmental outcomes. This is just one of many. Next. This is where I get really, really excited. is the application of it. And I alluded to this at the outset, and I would encourage all of you, even if you don't have single ventral physiology, you don't have stage 1 Norwood procedure patients in your unit, is in the management of critically ill patients for all the things we talked about at the outset. And it is certainly true for managing a post-op Norwood patient, which is delineating the physiology, giving you an objective, timely assessment of systemic oxygen delivery, showing you the limitations of blood pressure, certainly in a circulation such as this, including PDAs, showing you the response to therapies. And then this is one of the publications early on that talked about the potential role of regional, specifically renal somatic NIRS oximetry. Next. Following up in the previous study, this came out 3 or 4 years ago now, the benefit of monitoring renal NIRS in this patient population and in its role as an earlier indicator of a waning cardiac output, systemic DO2, and so on. And actually, they showed nicely in this study the relative insensitivity of central venous oximetry and cerebral NIRS, actually, compared to renal. And so many I would say that virtually all pediatric cardiac critical care units have NIRS in their unit, and the majority of them rely heavily on renal NIRS. Perhaps in some people's minds a bit too much, but there is evidence to support it. Next. And then I got one abstract to share with you guys, and then we can open it up. And that is this. I thought this was particularly neat, and it made me happy, so I thought I would include it. We participated, for all of you don't know, there's a Society of Critical Care Medicine, and pediatric critical care is within that. And the national meeting that just wrapped up falls within the SCCM umbrella. And the 50th anniversary was, well, now 2 years ago. And in this, it's a compendium of summary statements that reflect upon the 50 years of critical care medicine on diseases such as ARDS, sepsis, trauma, you name it. And one of the sections was dedicated to neonatology. And you all know some of these contributing authors for the neonatal contribution, some Hall of Famers. And this is what they published in their review manuscript. And I think it's quite interesting. NIRS-based monitoring, regional tissue oxygen is fast becoming a standard. That might be a bit of a overstatement. Non-invasive bedside technique in NICU, again, favoring personalization of care to improve short and long-term outcomes. I love that. That's from your own people. And I would encourage you all to apply not just in this assessment and management of perinatal asphyxia, but also in the neonatal patient. And certainly if they went down the hallway and we're in the cardiac ICU, we wouldn't ignore the brain in terms of a primary neurologic injury as you all do. But for us, it's every minute of every hour of every day, the whole body, whether you have pulmonary hypertension, cardiac dysfunction, systemic vascular issues, and so on and so forth. So that to me would be great as well if we could apply it in a broader sense. And that is it. Yeah, I think you guys got it after this.
Great. Well, thank you so much. That was a wonderful presentation. For the members of the audience, if you had any questions for Dr. Bronicki, feel free to put them in the chat. I had a couple that I wanted to go through. One of them is based a little bit on the one of the questions in the chat about transfusion. So you talked a little bit about oxygen carrying capacity. What role do you see for the use of NIRS, either to decide whether it's time for a blood transfusion, monitoring during a transfusion, or a response to transfusion afterwards?
Yeah, the idea, one of the things that I've thought about as I give neonatal presentations, I get invited to do these talks, and it's a neonatal audience, is I obviously have to dive into the neonatal literature and see what's of interest to you all. And two of the things that I thought that are quite interesting that I think provide a role for NIRS oximetry is there's a lot of discussion. When do you intervene on a ductus, whether it's pharmacologically or surgically, and when do you transfuse a patient? And I get the risk of all that. I have a clear understanding of all that. But one thing that takes out some of the emotional, subjective component of all that is something that's objective. And that would be NIRS oximetry. And if you apply, it's fascinating. If you think about one of the things that's fascinating to me, and here's I get excited like this. I love this stuff. If you go into pediatric ICU critical care, one of the things that you see all the time is something like bronchiolitis. And people are bored by it because it's so common. But it's such a fascinating disease if you really think about it, because it can give you airway disease, parenchymal lung disease, and everything in between. And the same is true about PDA. It doesn't get enough love. PDA is fascinating physiology. And if you apply a cerebral NIRS and a renal NIRS to a patient with a ductus arteriosus, and if you go, one of the things, I took it out of this slide, one of the benefits of NIRS oximetry is it makes everybody think a bit more, and I'm being kind. It makes us all think a lot more in a much more deeper way. And if you think about NIRS oximetry the right way, there's a lot of stuff in it. And it's much more than blood pressure good, baby good, blood pressure bad, baby bad. And you apply it to a patient with a ductus arteriosus, and then you begin to appreciate how twisted that physiology is and how at risk, not only kidney perfusion is and mesenteric, I would argue cerebral. If you apply that PDA, and it brings into discussion what is an adequate blood pressure to perfuse the brain, but suffice to say that if you have a shunt that's quite large, and in a PDA that's of large caliber, and particularly if you have a patient who has elevated peripheral resistance and elevated blood pressure, your QPQS can go through the roof and compromise systemic perfusion, including the brain. And that's been shown from studies that go back to the 70s and 80s. And that's despite a normal, if not elevated blood pressure. And you begin to appreciate, well, some very interesting physiology, by the way, but then some objective indicator of when is it time to then intervene on that ductus arteriosus pharmacologically or otherwise. The same is true about a blood transfusion. And how do you look for what impact does it have? Because if somebody says, okay, their hemoglobin is now X, and I think we'll transfuse, and you place the cerebral NIRS, and let's take out Valerie's true, the fascinating world of perinatal asphyxia that she's done a lot of research on. Take a baby who's transitioned now, hang it on the unit, and all that's done, and the cerebral NIRS is oscillating in the 60s. I would not expect the blood transfusion to have much of any impact on that cerebral NIRS. So if you give that patient blood and they say, well, the NIRS didn't change much, either it's Bronicki's NIRS is not right, or the blood didn't do anything. And neither of those criticisms are valid. They're both incorrect. What's wrong is that the person making that comment doesn't understand the underlying physiology. So it can provide you an objective indication of when and how to assess the need for blood transfusion and the impact of it on the circulation. And I think we cover that in the slides. I could certainly dive into that deeper, but I think the idea of getting facile with NIRS oximetry will get us to that point.
Ron, I think you're totally speaking our language. Like, I think you could be an honorary neonatologist, but I just wanted to.
The only reason I know that is because I prep for my NIRS talks with you guys, so I have some sense of what makes you guys happy and excited. Yeah. And in all seriousness, though, it is fascinating to think about that. And you guys, I'm sorry to interrupt, but you guys have studies on the transfusion where you incorporate NIRS and do it the right way, which is an extraction ratio. I don't believe, well, there's a couple studies on the same with the ductus arteriosus as well.
Yeah.
Anyway, I'm sorry for interrupting, but I got a little excited.
No, I think we're all excited. I think I was going to add that, like at our institution, for example, our clinical protocols for transfusing now have been adapted also to utilize cerebral NIRS. So just like you said, if you're within a normal, maybe a hemoglobin or hematocrit range, but your cerebral NIRS is low, that might be an exception. And that might actually, on the other flip of the coin, be an indication to transfuse that baby. Same thing with the PDA. We look at renal NIRS at Stanford, and if that's, reading low, that's also another kind of impetus that maybe this is a hemodynamically significant duct that needs to get treated. So I think it's great that people are thinking this way.
How about this? Let me add to that, Valerie. And I talked about delineating the physiology and assessing the response to interventions, all of which are important, right? Because if it's going the wrong way, and at a minimum, NIRS is a trend monitoring, you might want to back off, reverse the therapy, or we're getting further behind. It's time to do something now. Take, for example, I'm not a big fan of ionoconstrictors. Dopamine is an ionoconstrictor. And truth be told, you guys are big fans of dopamine. You take a ductus arteriosus, who you think is over-circulating, the lungs are wet, and then you place them on dopamine. I promise you, the SATs will go higher and the respective NIRS will go lower. And in doing so, you demonstrate that we just worsen the overall hemodynamic milieu of that particular patient. So it's not just helping us decide, is it time to proceed with an intervention, but how we got there, because that may actually stave off the need for any pharmacological surgical manipulation, get us back to where we wanted to, and allow time for the ductus to involute even more. But if you don't do the right things at the right time, you will get to a situation where you have to have a discussion with the surgeon in earnest, and we need to act now, and NIRS may be the tiebreaker. I would like to think that we could intervene earlier and then say, despite having done the right things, like an inodilator, we now have evidence of mesenteric ischemia, renal ischemia, brain ischemia. We can't feed, we're reluctant to feed, it's time to close it, rather than the surgeon saying, nah, I don't see it, and then push the envelope, and the next thing you know, you have neck, or you wonder why you have AKI, or worse. Yeah.
Yeah, great discussion. There's some other questions in the chat. Zach, I don't know if you want to get to one of them. Really great discussion.
Oops, sorry, I was muted there. Yes, I was going to merge one of the things I was going to ask with one of the questions in the chat box, talking about oxygen extraction, or FTOE. So my question was more of a practical one in real life. So none of these models actually tell us oxygen extraction ratio or an FTOE, or that's something we have to calculate. Just on a
Zach, I think you cut out a bit.
Yeah, my computer is acting up today. Just on a practical level, for those measurements, is that something you incorporate in rounds, or do you just do the calculation mentally? And then the related question that was in the chat box, which do you think is more important, the actual saturation measurement itself versus the oxygen extraction ratio?
Yeah, I think that's a a very good question, and a key point is you can't look at the cerebral NIRS in isolation. You can't look at any NIRS or any venous saturation. And I talk NIRS, venous oximetry interchangeably. You can't look at any of them individually. They have to be looking at in the proper context. And the proper context is you have to consider the arterial oxygen saturation and do that extraction ratio. And no, you don't have to compute it. You just have to issue it. It is the NIRS trended from, take a PDA, saturations in the 90s, and the cerebral NIRS now trended downward from the 60s to the 50s. That extraction ratio went up from something like 40s to 50s. That's how I would look at it if I was at the bedside in St. Louis with you. To me, the extraction ratio, it's not the NIRS, cerebral NIRS rather, it's the extraction ratio trended upward from 40s to 50s. We're going in the wrong direction. If it was due to dopamine, in my mind, the first thing would be you increased peripheral resistance and the arterial blood pressure, which drove more blood to the lungs at the expense of QS. If it was a patient that you and I are running on together and the arterial saturation fell and the cerebral NIRS fell accordingly, the extraction ratio would probably be about the same-ish. So in that case, the cerebral NIRS fell because you had a decrease in oxygen content, but the extraction ratio would suggest that as the saturations fell, blood flow increased to compensate. And so one of the great examples that I tell when I give this talk to anybody, but particularly neonatologists, it was a patient who had, and I'll make this quick, patient that, it's a true story, we're visiting this unit, PPHN, team was up all night, and they were flirting with ECMO, intubated, sedated, yada, 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 on the vasoactive stuff, just finished an echo, right to left shunting at a stretch for Amano Valley. And the question was, he's desaturating? We need to go on ECMO. Well, maybe, but the desaturation was in the 80s. The cerebral NIRS was in the 60s. So that's compelling objective information, that the amount of blood being shunted across is such and not at the exclusion of VO2, which has to be reduced, intubated, sedated, fully ventilated, muscle relaxed. VO2 has been reduced as much as you can. There was no cooling. That the VO2 DO2 relationship is adequate, in part because you're shunting right to left, maintaining filling of an LV. That's how you get into trouble with pulmonary hypertension, right? Is inadequate pulmonary venous return, as well as adverse ventricular interaction. So if you can get blood across the septum and fill that LV, you have, I'm not saying blue ribbon cardiac output, but adequate, which either partially or fully compensate for decreasing content, particularly given the fact that they rightfully decrease demand considerably. So that's a good example. It's a lot. I give a lot of long answers to questions I get excited about. You can't look at the NIRS in isolation. You have to look at it in terms of arterial. And I would go a step further and say everything, heart rate, blood pressure, to try to put together a hemodynamic profile.
And then I lost my chat box when my computer had a hiccup, but there was a really great question about unilateral versus bilateral monitoring. Valerie, do you still have the text up there?
Yeah,
I got it. Yeah. Go ahead, Valerie.
Oh, no, Dr. McGalley is asking, what do you think, because there's a cost differential for using two sensors versus one. So is there an advantage to go from unilateral to bilateral cerebral NIRS for hemispheric regional monitoring? And of course, sometimes this becomes a real estate issue too, depending on the size of the baby.
Yeah, it's a good question. We routinely have on one side, no doubt, at least because of the cost. That's fair. That's fair. And realize that if you put it on either side, or if you take it off and put it on again on the same side, you will have a different reading. And naysayers will say, well, that's proof that it's flawed technology. The issue isn't the technology is flawed, it's a person making that comment. If you take it off and you put it back on, you will get a different reading because of what we just described about 35, 45 minutes ago. That being said, no, we put it on one side. I suppose if you had a significant hemispheric lesion and you're worried about adequate perfusion and cerebral tissue oxygenation, I would put it on both sides, but I wouldn't put it on empirically because of what Carly said about the cost is absolutely an issue. Yeah, and real estate for you guys and your very low birth weight infants. Yeah.
Great. Well, I don't think there are any other questions. I wanted to emphasize one point you made earlier about the importance of this not just being another number, but the importance of incorporating numbers, with a plan of action, understanding both the physiology and what you're looking for to see improvements that what you're doing is working.
Yeah. Yeah. And the other thing that comes, if I may, Zach, the other thing that comes to mind, I hear comments and I get it. And I particularly get it after reviewing Valerie's study and others looking for a protocol to treat these patients. And I'm not a fan of protocols. They have a place to a certain degree, but there's no substitute for troops on the ground and having as much technology as you can at the bedside. In this case, you're talking about a non-invasive tool, which I know particularly an issue for premature and actually all our kids, right? Risk of infection, thrombotic complications and all that. It's a non-invasive tool that provides a lot of information and makes us think in a much more robust way. And it's not just a Zach and a Ron, it's all of us, including frontline providers, nurses, and there's a lot of information you can glean from it. It does have its limitations, but there's many more advantages and disadvantages to NIRS. But to think that there's an easy way out of it with a protocol will help. And I suspect that's what you all are working on as these high-risk patients transition from in utero to extrauterine, but there's no substitute because there can be other factors going on that I alluded to, like your PPHN patient. I just slipped. A patient with perinatal asphyxia could very well have had PPHN, myocardial depression, and both. Well, that's not as important as brain injury, but it can cause or contribute brain injury, and you still have to worry about the kidneys, the gut, and everything else. And so, for those reasons, I would encourage you all to apply it in a broader sense. Think about the brain, but think about everything else, because you guys have a lot more fun with a lot of stuff than we do. We don't get to see PPHN like you do, and the meconium aspiration syndrome, the dynamic changes that occur with surfactant replacement therapy, and so on and so forth. Yeah.
That was an amazing session. I really appreciate your time and for actually all of you for joining us today. So I think since it's the top of the hour again, just a reminder, this session has been recorded and will be available for viewing in the future as well. And just thank you again so much, Dr. Bronicki, for talking to our
Thanks for
group.
having me. Thanks, guys.